Hey guys, just a reminder, this is not official medical advice. For such, please seek an appointment with a licensed medical provider.
Ladies and gentlemen, we're live. This is another episode of Explain This. It's not with Robin Riddle today. It is with Andy and Bo McGregor. Welcome back to the Thunderdome, as I say. How's the weather down on floor one of North Knoxville?
It's great. It's beautiful, sunny, a little chilly, but we like the sun.
You have a high def gloss on your face right now. I think you just came off the runway.
Not at all.
Something's happening. Okay. Bo and I, too, would like to take a little, we're going to call it Ode to Hair. We're very proud of the hairdos that we have, and we've got a lot of it. So if
We get comments around here.
we're getting comments on our hair, too. Bo's going the all natural round. I'm on a lot of pills for it. Um, so we know both ways to do it. Okay, today, so we're doing a quick podcast today too, because we wanted to talk about GLP-1 therapy and GIP therapy, or the umbrella term is incretin hormone therapy. This is what everyone's using for weight loss. Weight loss into technically diabetes management and
Yes.
decreasing or improving or sensitizing insulin resistance. I know it very much from a diabetes standpoint because I actually used to work for Novo Nordisk and was trained on liraglutide or Victoza or Saxenda before Ozempic, which is Semaglutide, came out. But now there's Tirzepatide, which is Zepbound Mounjaro. There is going to be something called Retatrutide, which does not have a brand name yet. And there's even a new one from Novo Nordisk that includes the hormone amylin. And it's
Oh,
going to be a
wow.
combination therapy of semaglutide and amylin. So there's a lot coming out, and I wanted to bring Bo on here because he has 11 years of critical care experience combined with ER experience, and he has seen what sometimes can
I've
be
seen some things
like
and
the bad
like and
side.
and also I just want to talk about a little bit about the public awareness of these things and kind of dispel some of the bad things people think about these drugs. I think that we see what the media portrays, and people kind of hard to say abusing, but overusing
Mhm.
and losing too much weight and losing muscle. That's not what we aim to do. And since kind of coming on this side, I see way more improved effects of people with this medication. Just as my experience, I think I seen one case of a person ending up in the ICU, plus or minus. Was it due to Ozempic? I'm not sure, with pancreatitis. But also, were they followed by their physician very well? Were they taught about gut health? Were they told about signs and symptoms of pancreatitis? And if you have these signs and symptoms of severe abdominal pain, nausea, vomiting, to stop taking the medicine and call your provider.
Yeah.
These things can be avoided, and if noticed early, then we can prevent hospitalizations, severe pancreatitis, and avoid those things. And since being here, no, seeing how well these drugs work and these
Yeah,
medications work.
was that a surprise to you?
Well, yes.
Okay.
And if used correctly, just like everything else, and improving somebody's health span and lifespan, improving their metabolic health, them seeing weight loss results. And I've been recommending to everybody I prescribe this to go get an in body from our West office before
Yes.
starting these medications, because then it shows their body composition and how, when they are losing weight, what weight are they losing? Are they losing the visceral fat that we want to get rid of and keeping our muscle, or gaining muscle? And teaching kind of our population to not worry about the number so much, worry about your composition of weight. If your number starts to slow down as you're losing weight with these medications, but your muscle mass improves, but your visceral fat and body fat keep going down, and you're getting that composition that you want, that number doesn't mean as much as what that means.
And two, so much of it is all about the risk benefit, I think. So much that we have I feel like there's a tendency sometimes, and maybe you can correct me if I'm wrong, especially in high level acute care that you came from. You saw the worst of the worst. You saw very sick people. So when you see that type of patient, it might color the experience of the provider to say, oh, Ozempic's bad. Oh, Mounjaro is
Ab-
bad. They're all bad. They cause pancreatitis. It's like, no, you saw one case, and technically, I think the actual percentages are super low. I think it's like 0.2 or 0.3% of people who take this will get it, and a lot of it might even be just their body chemistry or how it does slow the digestive tract. You have a gastric delay, which can put pressure on the biliary system and put pressure on the pancreas.
And again, it all like we don't know the education that could have been performed prior to administering these medications and prescribing them. When we give, so when we start patients on this, we give step by step instructions on how to dose it, what's expected. Your body's going to take a little time to get used to this. We give all information about your gut health and maintenance throughout these medications to be aware of your gut motility slowing down. You could have some nausea if you're having constipation, what to do. If you haven't gone in a couple days, there are some things to kind of improve that. If you haven't gone for a week, then you can get in trouble, just
And
like with anything else.
not letting that stuff back up and build up. You got and we usually, so every one of our patients here in all of our offices get a like a handout that tells you about how to preemptively prevent as much as you can the gastric delay. So how to support the microbiome, how to get prokinetics within the gastrointestinal tract, magnesium, Dr. Schultz. There's one even called intestinal bowel mover, things to keep things moving while you're slowing things down. I would venture to say I spoke on this at a convention one time, and I mean I was obviously the only person in integrative health that used compounds, and the guy before me literally said all compounds are terrible. He's like, if you use a compound, you're going to kill someone. I was like, we've been in this for a long time and people are not dead. And so a
And
lot.
that may be in one experience like mine that
Exactly.
maybe the pharmacy wasn't reputable. I don't know.
Or two, even I know we're talking mainly about incretin hormones, but I spoke at my PA school one time, and one of the professors there, who's brilliant and amazing and had a lot of ER experience, she was very adamant against using Armor and MP thyroid and T3 replacement because she saw a lot of people come in with AFib. So she had a negative experience with the drug. So a lot of that was like, yes, that is a negative experience with that one particular, and maybe that's not a trusted person or provider to go to. That's the hard part about what we do, is that anybody can do it. You can pop up
Well,
a clinic very quickly,
and
but
also too, coming like us as we're prescribing medications, they're only seeing that small percent of things that could go wrong,
because you're in the ER and
and
you're in
we're
clinical
seeing
care.
people on follow-ups where everything's going right, and that's
Yes.
the big majority of them: losing weight, feeling better. NP thyroid, they've been on levothyroxine their whole life, start them on NP thyroid, and they're like, oh, I actually feel something.
And two, some of it you can't throw the baby out with the bathwater, and that's with anything. That's with anything in life, but definitely medicine. I'm curious to know, just because you're at that high level care, like, what did you think of integrative health outside of like, because too, Bo reached out to like you reached out to us to just learn more. You're just curious about learning more. Did you
Yeah.
have a connotation about what this particular like facet of medicine was?
Um, you know, I didn't know a
No
whole
holds
lot.
barred. You can say anything you want, okay?
No,
And we'll
I like
edit it out.
honestly, I didn't know a whole lot, and I've told a lot of people this story. It's kind of like, you know, been in the hospital for quite a long time, and it had become very different from when I started with the patient population, how sick people were, what's happening, and you do some research, and first thing you know, you're getting all these feeds and you're like, well, what's this? And like, this is different. This is a different way to think about things. Um, and then you start to say, well, that's interesting. I haven't ever heard this before. And then you do a little bit more research and come to find like, and this is the way that I think medicine should be. It should be a whole body kind of think about it from a whole body, not just particular system all the time. Think about how the patient is and include the patient, inform the patient in the decisions that they can make for their health care.
And two, being willing to try something. It's like,
Yeah.
why not? What we talk, and we've spoken a lot of this too, as we've had new patients come on and are just wanting to lose a little weight. It's like, okay, we really need to hit the obesity category in order to keep weight off, especially too for specific patient populations that have a very difficult time keeping weight off, which is the menopausal female. She has a much harder time and a much lower basal metabolic rate. I see it on InBodies all the time, where it makes it very difficult to lose and maintain weight, and it's very easy to gain. So it's why
Yes.
not have this tool available? And I even actually think Tirzepatide is going to have an indication for. I wouldn't be surprised. I know that it's being prescribed a lot within this category of patients, but it's just interesting to hear from the critical care standpoint that
Well,
not
and
everyone.
also, how we're educating people on like what doses to take and things like that. We want the least amount of medications, maximum effect without side effects.
Yeah.
And telling people, we'll go to where you're happy, but also when that food noise kind of turns off, that may be your set point, not just maxing out a drug to max out a drug.
I have another question. This is an ICU question, because too there's different. Now that a lot of people are on these, are creating different protocols on when you discontinue them or stop them prior to surgeries or stop them prior to colonoscopies or endoscopies or procedures, because of the gastric delay.
Hmm.
Did you see now? No, the recommendation from what I know is that it's at least a week for surgeries and maybe 2 weeks for colonoscopies. I'm curious to know if you saw that come to you.
I don't know if I would have seen that at all. I think if I would have saw something to that effect, I probably wouldn't have known
Okay.
that that was the cause of it. Plus, if it was like a gastric issue, we would have been more of the medical management part of some surgical procedure or something like that. So to hone in to be like this was the problem in that kind of acute situation, I don't think I would have known at that point.
Just
But like I said, like on the pancreatitis person that I saw, it was kind of a plus or minus that this could have possibly led to her pancreatitis. I don't know. It was kind of on exploration of like, have you started anything new lately? What have you been taking and things like that? And that happened to pop up and just kind of linking that to her pancreatitis.
so it's maybe not just like that was the only thing super
Yeah.
healthy, the only thing she started. So too, I think too, I'm hoping with this particular podcast and our message is that we want to continue to dispel myths about we want to continue to dispel myths about anything. Sorry, I just lost my feed here. Okay, there we go. About incretin hormone therapy, GLP-1s, GIPs, because a lot of people are going to be on these, and they're only going to get more popular, and there's only going
Yeah.
to be new ones that come out. And two, there can be I don't want people to fear doing it. So this is great that we have like someone with
I,
critical care history. They're
like I think from what I've seen in the time that I've been here is that it has dispelled a lot of myths and I don't what is the other word? Kind of the picture of what somebody looks like that's on Ozempic.
yes,
That's
yes,
kind
yes,
of what
yes.
people say. It's like, oh, they're on Ozempic. Oh, they're on. Well, they may be, but if they do it properly, it's going to help them and their overall health in the long run.
And to be able
Because
to say that,
decreasing heart disease, decreasing rates of chronic kidney disease, helping out with diabetes or avoiding diabetes if you're pre-diabetic. going ahead
Yeah.
and getting on that train. Let's get healthier. And it's motivating once that people start losing weight and feeling better. Then they're like, "Hey, let's get in the gym. Let's do these things. Let's get healthy."
Let's eat better. Sometimes it's
Yes.
really hard.
Yeah.
At that same conference that they kind of like poo-pooed compounds, there's
Yeah.
one guy who's like, who wouldn't like, it was amazing to me. They said, who would not, would prescribe a drug like Ozempic, Mounjaro, or any of the, he didn't say the compounds, but
Yeah.
Semaglutide, Tirzepatide, um, without making someone go through an exercise, like prove to you that they exercise and ate well. And I would say at least half or a little under half of the providers there said they would never think about prescribing someone any of those drugs unless they prove to them. Like, prove to you? I was like, what
I, I would.
are you living with this person? What are you
Yeah.
trying to prove? It upset me because pe- people need help.
Th-
People need help.
this may sound really bad, and you may want to edit this part, but you could also look at them and say, "Hey, why don't you look in the mirror?"
We'll we'll keep it in. We'll see what the live feed there from the office says about that. It is that
No,
is
no, I'm kidding, but like,
that's another important thing
you know,
too. A lot of it is as a provider, especially within this industry, you do want to practice what you preach, and if you want to be, I think as healthcare providers, we should be pillars of health.
no,
I genuinely do.
and I mean, to be honest, like I was saying that kind of tongue in cheek there, but you know, we don't know that person's lifestyle. We don't know everything that goes in and out of their day. And for us to demand something like that from somebody,
Proof.
what if they like prove what? Like you
That,
you could prescribe blood pressure medicine without them proving that they haven't tried to lose weight or exercise.
That's a good.
Sorry.
I mean, it's a great point. It's a great point, and really the big thing is, yes, we're dispelling myths, but it's just so nice to hear it from a critical care standpoint, where the worst of the worst comes in. That's not everything that you're reading or actually seeing in the ICU, and I think that can
No.
give patients and people who are interested in pursuing this, to be a little bit kinder to themselves, that it doesn't necessarily have to be a crutch, but it can help you. I always say a lot of the things that we do help combat what the modern world has done. There's a lot of
Hmm.
great things about the modern world, but that comes with it comes with a cost. As we make
Yeah.
things a lot easier, we also make other things a lot harder. And so this
Yes.
is just
Yeah.
another tool. And that's to say too, as you approach this, and I feel like you hit it on the head. Approach it approach it with care. Like, be kind to your gut. Make sure it's moving. Don't let things get backed up, because you don't want to be that 1 point. You don't want to be the 0.2% that does get pancreatitis or a gastric outlet obstruction. You don't.
Hmm.
So there's just different ways to do it.
There are many different ways, and it's if it improves people's lifestyle and health, and if it gets them on the right path of being healthier, being motivated, start looking for the right foods because they're seeing results. I don't see the downside of trying.
And two, just to throw this out there to our patient profile and listeners, I get questioned quite a bit about, well, are you seeing anything about long-term side effects? Are we going to be a part of that commercial that's with mesothelioma and and mesh, stuff that you read about later? I've read none of it. I've read absolutely none of it. All I've read is that it's just going to be indicated for more and more things, that it could
Hmm.
be for mental health, for alcohol use disorder, for ADD. I've seen it for migraines. I
Yeah,
think,
I even your dad said something the other day that it can sometimes help people quit smoking,
yeah, I only
like the addictive kind of issues.
I only see good stuff, and two, we won't have long-term data. So two, there is a risk to taking this. I think that's important to know. But with anything that you do in life, there is a risk benefit. So I think for right now, for most people, I think the benefits outweigh the risk, and it's worth a shot. It's worth a shot. Oh my God,
I,
that's the campaign for it, right?
I like when you're dealing in this world, when you're out in public, you see people like they could benefit so much from either GLP-1s, hormones, anything that we do here. It's almost eye-opening of how some of these things can really, really help people.
I think it's great. Well, you heard it here first. Bo, thank
Or
you for
second,
joining
I
us.
don't know.
We heard it here first, only right out of the horse's mouth. Thank you for joining us. We're so glad to have you in this wealth of knowledge and experience. And two, if you feel like looking into the GLP-1s, GIPs, come see us.
Come see us.
Rock on. Okay, for another episode soon, we will be talking about antibiotics soon. Bo and I are going to do a deep dive into antibiotics. I'm just going to be here to moderate, and Bo's going to do all the research. Thank God. Until next time, thanks for joining us.
Don't go away.